Okay, so we'll use this. So thanks very much. Thanks for the introduction, and thanks so much for inviting me here. And I know there's already been thanks to IPC and Holly and Sarah and the team, and we're really grateful at the Cancer Center for everything they've done to help. Sorry, can't hear. Okay.
Yeah, maybe if you just speak a little more directly. Yeah.
Okay. I'm ready. Okay. So I'm Dr. Livergant, Jonathan. I'm a radiation oncologist. And I'm talking today about monitoring PSA levels after treatment and what that might look like and what might happen if they start to rise. This is unfortunately, I sent a very old version of my slides to Holly. I was telling her that as I was walking out the door, my wife said, bring your slides on a USB key. And I said, no, it's fine. I already sent them. And I think that's why I'm being punished by having sent the wrong ones and not listening to her. But so, I've apologies for that. And I'll try to say the things that should be on there. In fact, these are so old, I didn't even know that the name of the meeting has changed from peer support meeting to the speaker series. So you can see. So we'll talk today about what a biochemical recurrence of prostate cancer is, what treatment options or what investigations may be done after surgery with a biochemical recurrence or after radiation, and then what treatment pathways there may be for that. And this is my first time trying to use, I'll see if I can move this a bit. Maybe that's you on there. Anyway, that's okay. Some AI art for this presentation, in which I abandoned after a few slides, which you'll see why. But I asked the computer to generate some men here that have had treatment that, so we're not using real people. But this is a Serge and Artie. They're 64-year-old men. They've been diagnosed with intermediate risk prostate cancer on their biopsy. Their initial PSA is 10, and they're going to go down different pathways for treatment, and we'll see sort of what happens with their PSAs, what options there may be. Serge, of course, chooses surgery, and RT has radiation therapy or RT, prostate saber, which is a high-dose focused treatment to the prostate. So this is the computer imagination of our laparoscopic prostatectomy. Has some room to grow before it takes over for the doctors, I think. But surgery shows a very typical intermediate risk prostate cancer, Gleason 4+3 disease, so sort of intermediate aggressiveness with a little bit higher of the pattern 4, so higher tier in that category. It's involving about a third of the prostate gland. And it's starting to spread beyond the capsule of the prostate, but hasn't gone to the seminal vesicles or the lymph nodes nearby. And the surgical margin is positive, meaning when they took the prostate out, they look at it under the microscope and they say, well, there's cancer on that side of right at the edge of the specimen that was taken out. So there may likely be cancer on the other side that's still in the body. But regardless of all that, the most important factor afterwards is the PSA after treatment. And for him, his PSA became undetectable after when the first test after surgery a couple months later. Is this yeah, I'll come back to that. So after surgery, your PSA should become undetectable within a couple of months, because the only way to have PSA, this prostate-specific antigen, is secreted from prostate cancer cells, which are either prostate cells, which are either normal prostate cells or cancerous cells. So if there's something that's generating PSA, then it's not something that we intended to be there after surgery. And oh yeah, so that's right. So here's the initial PSA levels. We're sort of climbing. The numbers are not very important, and just this idea about the graph, though, that after surgery they should become undetectable. Any rising PSA or any persistent PSA afterwards may indicate that there's cancer cells that are left in the body. How likely it is that the PSA may start to rise at some point after surgery, or if it's persistent and rising, how aggressive that might be, can be based on what we see at the time of surgery. So how aggressive the cancer was and what it was looking like under the microscope, as well as what the absolute number of the PSA is and how quickly it's changing. Those can also give us an idea of how likely it is that the prostate cancer is still within the surgical bed. So if the prostate's been removed, but the PSA is not 0, or sometime later the PSA becomes detectable, then the possibilities are that there's prostate cancer that's still in the area where the surgery was, and it just was too small to see and it's sort of growing slowly, or that it has spread somewhere else. And if it's still in the area where the prostate was, the prostate bed, then there may be an option for local treatment with radiation to try to eradicate it and change that to a cure. Yeah, so it used to be that if there were like 10, 15 years ago, that if there were high-risk features after surgery, there was a higher chance that if cancer may come back, that everybody would be offered radiation. And people would have radiation within 6 to 12 months after surgery, as soon as the leakage was healing, to prevent that from ever coming back. But over time, there were several studies that showed that if we wait until the PSA is about 0.2 and then gave radiation, then we can safely delay radiation, which is a quality of life benefit for people that have had to have both treatments. And about half of people never end up needing it. People that do have very high risk of cancer coming back after surgery may not be well represented in those studies and would be probably best discussed in an individual scenario. But the idea is that, for example, here in one of the studies, if they're in the red group here, this is the percentage of people that have had radiation. So again, the numbers are not important, but just this idea that at the top there, 100% of the people in the red group are randomized to having this adjuvant radiation. So standard postoperative radiation, they all have it early. In the blue group, if you wait until 0.2, then even in this study, 8 years later, less than half of men have needed it. So, and many of them have had it delayed for several years. So this is a curative intent treatment for prostate cancer that's recurred after surgery. And the goal of radiation here is to get rid of the cancer completely and never deal with it again. They call that freedom from biochemical failure, meaning the PSA never goes up again and never becomes detectable. And the cure rate, the success of this treatment, is really based on the individual prostate cancer and what we saw under the microscope and what the PSA is and how fast it's changing. Yeah. So thanks. Yeah. Again, the number's not that important, but this is a chart that shows the chance of cure just based on the PSA. So this is a chart of time over year, like this is years since radiation, and then the percentage of people that have had this freedom from biochemical failure. So the percentage of people that have no issues with no PSA coming back again in their life at that time. So the top line, the blue group, shows that 10 years later, if the PSA was 0.2 or less by the time you had radiation, then the chance of cure in that scenario is about 60%. And in the bottom group, if your PSA was 2.0 or more by the time you had radiation, then the chance of cure is about 30%. This isn't the whole picture. There's many other factors to consider that kind of go into this, but just this idea that earlier treatment, maybe not super early before you even have any PSA going up, but earlier treatment does increase the chance of cure and the benefit of radiation. And that it's also not a entirely useless treatment, even if the PSA is much higher. Like the trade-offs may be different, the discussion may be different, but there's still a possibility of getting rid of the cancer, even if the PSA is as high as 2. And this is, again, just this biochemical recurrence. This just means the PSA is going up. It doesn't speak to whether the cancer has spread to other places or is causing any issues or is threatening anybody's life. So this is where the slides start to break down here. And also the computer imagination of a gentleman having prostate radiotherapy here at the hospital, which I like to think of as, shining a light. I don't know. It's just not quite that. we got, I don't know. I kind of like the picture though. So Artie's had prostate saver. So stereotactic radiotherapy, you know, our historic radiation treatments were every day, Monday to Friday for 7 or 8 weeks. And then the studies showed that we could do with more modern techniques, a little bit higher dose per day over a shorter number of treatments. So our standard right now in the last few years, like 2 or 3 years, is 20 treatments. But taking that to the extreme, you know, we have started as well saying, well, can we do an even higher dose per day over just 5 treatments? And that's very typical a treatment that we're offering right now. Still doesn't look like that, but with radiation, PSA drop. So this is a chart of that prostate saver treatment, and this is a group of patients that have had that treatment. So they've got points which are the average, and also these error bars representing the where people may be within that. So after treatment, the PSA tends to go down, but it's not necessarily a steady progression. And in fact, it can bounce up before it goes down, even a year or 2 later, before it settles to its lowest level. So certainly following the PSA after radiation can be more difficult, but also more, I think the psychology of it plays into it, that it can be more difficult to see the PSA fluctuating, sometimes going up or down, and also knowing that it may take 2 to 3 years before we know what the result is of the treatment. But you see in this group that most of the patients, by the time it's, again here, so 24 to 36 months when it really starts to get to that flat line. It never really goes to 0. It can sometimes, but typically it does not become 0. We like it to settle less than 1. So how do we know if the prostate cancer has come back, knowing that it can fluctuate and it doesn't become 0? And there's been different definitions over time, and the one that's accepted now and used the most to compare in different studies and to compare different people is to say, well, we wait till it gets to the minimum. If it ever goes 2 above the minimum, 2 above the nadir, then we would say that meets the definition of biochemical recurrence, meaning there's a PSA telling us that the cancer is back, and then we should go investigating where it may be and then what treatments might be available. So we talked about surgery and local treatment options after surgery with radiation. After radiation, and this is something that we hear a lot from people talking about, that well, you can have radiation after surgery, but you can't have surgery after radiation. And while it's not exactly true, I think it's important to address that it's not very likely either. After surgery, some percentage of people that may be in that 20 to 30% require radiation after. They have a PSA that's going up, and we wonder if there may be some cancer that's left behind in the prostate bed. After radiation, if people have their PSA going up after radiation, it's a lot less likely that it's because of cancer in the prostate. So whether or not it's possible to take out the prostate when the PSA is going up after radiation, it's more likely that there's prostate cancer in the lymph nodes or somewhere else nearby than just in the prostate. So it might not make sense to take out the prostate. Trying to find out where the cancer is after radiation, if the PSA does go up, is very important to consider in order for us to consider whether we would suggest a difficult treatment like surgery after radiation, or there may be other alternatives for local treatment to the prostate if the cancer came back there after radiation, including more radiation, whether it's with brachytherapy or with more focused treatments, cryotherapy with freezing techniques, or surgery. But because the complications can be much higher after having had radiation to the pelvis already, we want to be as certain as we can with our MRI, maybe a repeat biopsy to prove it's there, and possibly a PSMA PET, which I'll talk about as well, in order to make sure that we're confident about where it is. If the cancer has spread beyond the pelvis, to distant areas, to the bone, to other places, then the treatment options are not curative treatment. Then we're not talking about ways to get rid of it completely, but rather ways to help manage it. And more like a chronic disease, something that will have to be monitored and we'll have to consider treatments over time. One treatment that's been, again, a historical standard is intermittent estrogen deprivation in that scenario, meaning we know that the cancer cannot be cured if it's come back. And one way to manage it is to use hormones. We talked about the ADT already, to knock it back and then let it come back up to where it is, to some target level, and use the hormones again to knock it back. And it seems to be that if we allow, people have different patterns of practice and philosophies, but somewhere in this 5 or 10 or 20 range, allowing the PSA to get up there as long as the cancer hasn't spread, as long as we're not in an area we're talking about adding in some of the additional new systemic treatments, which are beyond the scope of the talk today, then we can use the hormones to kind of knock it back and control it. And then you have a period off the hormones as well. That can work for a few years before the cancer starts to become resistant to it. And again, this is a treatment that helps control it, but doesn't get rid of it completely. So another question that has arisen sort of during this time is, well, if it's only spread to a few places, is it possible to aggressively target those places, probably with radiation or radiation and surgery, or depending on where it is? And then does that help people live longer or live better or delay further treatments? And well, there's been lots of studies in this area over the last few years. And certainly in prostate cancer, it seems that if there's only a few spots, for example, if you have a test that that shows that there's cancer that's come back, it's in some few lymph nodes or a couple of spots in the bone and a lymph node, then if we use radiation to be aggressive and target just those spots, then that can delay the need for further treatment. It can delay the time until the cancer becomes resistant to the hormone therapy, and it may help people live longer. So how do we find those, those areas and make sure that we're offering that if possible? And that's where this PSMA PET comes in. So we've had conventional imaging, the CT scan, bone scan, and MRI to look for where cancer may be. There's a newer investigational test which is being used, which is very sensitive for the location of prostate cancer cells. We have it on a trial at BC Cancer right now in Vancouver with a bit of a wait, and that trial has been, it sounds like they're very hopeful that this will show that it can be opened up more broadly and should be used more broadly very soon, but it's also available privately. And it's most useful when the PSA is a bit higher. So thinking about patients that have had surgery and their PSA is still very low, we know that when your PSA is about 0.4, about half of the time the test will show something. So half the time it doesn't, meaning whatever there is too small to see. But as that gets higher, at a PSA of 1, it's about 75%, and a PSA of 2, it's over 90% of locating something to say, well, this is where the cancer is, even if we didn't see it on the other scans. And that may allow us to offer more targeted treatment to those areas. So, my practice has certainly changed even from, say, 10 years ago, where we would say, okay, you've had treatment, you've had surgery and radiation, your PSA is still going up. We should plan for intermittent hormones to help control it. Wait till your PSA is 10, and then we'll start hormones to knock it back. Versus now saying, well, even though your PSA is very low, can we find out exactly where it is so that we can target it and consider these options, including new clinical trials that are using additional drugs in combination with hormone therapy or in combination with radiation. Yeah, so this is just a slide from a trial that looked at patients that have had surgery and their PSA was around 0.2 to 0.4, and they had a PSMA PET scan, and it showed that some patients, 12% or so, had a major change in their plan by having the PSMA PET. But there's the issue of delaying treatment in order to get the PSMA PET. So that's an important conversation that we're now having, where we have a treatment that we would offer, and now do we need to consider waiting on that treatment in order to have an investigational test, and certainly changing the way that we have these conversations. So I think the I think the idea about watching the PSA after, for me, is really about, if the PSA is starting to come up, trying to assess for an individual person where they are and what that means. And some of the factors about the original cancer, how aggressive it was, what it looked like under the microscope, what the PSA was, how long ago treatment was, and what the PSA is now and how quickly it's changing, can really give us an idea about how likely it is that the cancer is spread further, and to think about then the intent of treatment, whether this is something we can get rid of completely, or we would need to be managing without being able to get rid of it. And if that's the case, how can we do that in the best way, and find out? So yeah, I'm really interested to hear about all the questions that we have from the room and from Zoom about this, and how this applies to you. Thanks so much.